Good afternoon, everybody. Welcome to OHA's COVID-19 webinar series for healthcare providers. It's great to be with you today, February 11th, and we have a host of new information to bring to you. I'm joined by my colleagues, Drs. Jean, Cieslak, and Smits, and we're going to get started. Next slide will show you the outline for today. We're going to start with our usual EPI update regarding COVID-19. We'll get into vaccine update, provide just a little bit on OHA guidance update, and end with a literature review. So with that, to the next slide, I'm going to pass it off right up to Dr. Jean.
Thank you, and good afternoon, everybody. We'll start with a epidemiologic update, as we usually do. And I think, as you're probably mostly aware already, the news has been pretty good lately in terms of our cases. This is our epidemiologic curve going all the way back to last March. And you can see our large peak in the early winter and a pretty clear decline now in both non-hospitalized and hospitalized COVID cases in Oregon. As of yesterday, we had 148,000 thereabouts total cases. Cumulatively, 8107 hospitalized cases and 2,044 deaths. The hospitalized cases represent about 7% of all cases to date. Next slide. So this is also from our weekly report, and this is just looking at a kind of a week by week. So for the most recent week of data, we had 4,049 new cases, which is down 15% over the prior week's total and our lowest weekly total in 3 months. So that's really fantastic to see. Our patients newly hospitalized fell by about 8%, and we had 66 deaths, unfortunately, during that week. At the bottom there, you can see our test positivity with a little bit of a graph showing the trend over the past few months. And test positivity has been declining as well, about a half of what it was a month ago, and we're down to about 4.2% of all COVID tests are coming back positive in that most recent week, and about 112,000 total tests for COVID-19 recently, and that's been declining a little bit too recently, probably related to our declining cases. Next slide, please. Oops, sorry, okay. So this is some pretty important data that we are now including in our weekly report. And, you know, we've been reporting race and ethnicity data for a long time, but we are now reporting age-adjusted rates, both by different racial groups as well as ethnic groups. And this is important because there are significant differences in the distribution of those populations by age. So, for example, Latinos, Latinx tend to be a younger distribution than the general population. So we need to age adjust to really see what the relative differences are, especially for hospitalizations and deaths, because obviously the older you are, the more at risk you are for severe disease or death in general. So what we see here, these are basically ratios, and we've just set basically a ratio of 1 as the comparator for whites, and then you can see the relative risk for cases, relative rates for cases as well as hospitalizations and deaths for each group there. And what's pretty interesting to note here is that in almost every of those groups, those people of color, there is a significantly higher rate of not only cases, but also hospitalizations and deaths. And it's quite high for American Indian Alaska Natives, as well as Pacific Islanders. So there's actually all this and more in our weekly report with some other graphs on, for example, sporadic cases and some trend graphs for these age-adjusted numbers over time. And the next slide is the same thing for ethnicity, showing Hispanic versus non-Hispanic or Latinx. Again, once we age adjust it, you see that not only is the case rate higher for Latinos, it's actually quite a bit higher for hospitalizations and deaths as well. So just really highlighting the disparities here among these different populations. Next slide, please. Okay, so moving on to our risk levels. So these will be updated. It was announced by the governor that we will be updating a lot of these risk levels effective tomorrow. So this is the old map from last week. It's actually a 2-week period, and you can see that just all that red across the state. We had 24 counties in extreme risk, and only 8 in the lower risk, and then about 4 in the middle there. So we now have 12 counties that have improved, again, effective tomorrow. 10 will be dropping from that red extreme risk for the first time since November. And that is reflective of cases and test positivity. So, you know, it's exciting to see that. And then so effective tomorrow, there will be 14 counties total in the extreme risk level, down from 24. There will be 11 at high risk, 2 at moderate, and 9 at lower risk. So that will include the Portland metro area, which will drop from extreme to high risk. And so, for example, indoor dining will now be allowed under the high risk, although it'll be quite limited. So some changes there. It's definitely encouraging to see, although we want to remain cautious because you know, if we let up our guard now, we're going to end up right back in extreme risk in many of these counties. So, all right, next slide, please. Okay, and then finally, these are kind of familiar graphs, I think, to most people, but this is our from our HOSCAP data, which is effectively real-time data of our hospital census, showing the trends, again, all the way back to last spring. You see that large peak a few months ago and a pretty significant decline in the daily census of COVID positive patients. Top line is all patients, and then the bottom two are ICU and ventilated patients. So very encouraging picture here in terms of our hospital capacity. And then the final slide here is the same graph broken down by region, with region 1 as the blue bar. Very clear picture there, decline, just because it was so high in that region. And then, but even in the rest of the regions in the state, we're seeing declines for the most part. Next slide. All right, is this back to you, Dana, or Paul?
It is, yep.
Okay.
Thank you, Dr. Jean. Trying to work out an echo, I think it's okay now. So we're just gonna spend now a few minutes here talking about the status of our COVID-19 vaccine work. So just to orient everybody where we are in terms of moving through phases of eligibility for COVID vaccine in Oregon. So we've largely gotten through the majority of our first phase, phase 1A, which started back on December 12th. We know in some counties there's still extensive work getting through, particularly where there's a large population base, like in the Portland metro area, or particularly for some of those individuals who are eligible in phase 1A that are harder to reach or need a specific kind of mobile vaccine access to receive vaccine that meets their needs. So just as a reminder, group or phase 1A included healthcare personnel defined broadly across many different settings, as well as congregate care sites and others who receive in-home health or personal care services that might put them at greater risk as people move into their home. Those are just some general overviews. You can see in this infographic, we describe a little bit more about who those phase 1A groups were and have a much more detailed 10+ page sequencing plan for those. We have already moved into phase 1B starting on January 25th with child care providers, early learning, and K-12 educators and staff. Again, many of those have had access to vaccine already, with still some ongoing work to make sure to get through all of those individuals eligible. Again, we know several counties have largely completed that work, and there's still ongoing education-related vaccination efforts happening in other parts of our state. Likewise, we moved into the age groups that started this current Monday, February 8th, beginning with those who are 80 and older becoming eligible. And then week over week for the next several weeks, we'll move down in age brackets by 5-year increments, getting to all people 65 and older eligible by March 1st. Looking ahead, we are working still to operationalize and plan for the next sequences of individuals who will become eligible, building off of the recommendations from the Vaccine Advisory Committee, which are all found on our website. I'm not going to speak to those in great detail. I just would start here by acknowledging that we, as we move through these phases, and you've probably heard much mention of this in some of our public communication, we do still have limitations in vaccine allocations from the federal government. And while we are opening up to new groups, we still know that it will take weeks for adequate doses to get available, even for those who are eligible. So we expect through this month and into March that we'll be still vaccinating those who become eligible, particularly in these new age brackets, as we continue our planning for future eligibility groups moving ahead. Next slide, please. Oh, sorry, you can move forward. Forgot about those. So this is a reminder to have you take a look at our vaccination dashboard. This gives you trends over time of our doses of vaccine administered per day. You can see that we've been able to build both capacity and throughput, as well as receive more doses coming to our state over time. There's two different colors listed here. One is representative of Pfizer doses, that's the darker blue, and the lighter color is the Moderna doses with, as of yesterday, over 600,000 total doses administered. That includes both first and second or boost doses. On the bottom, you can see that just over 155,000 individuals as of yesterday and as of what we've received in our alert data system have received both doses. And the second doses are really building now as we get to that interval as recommended by the CDC for the second dose vaccinations. Just to put another data point on this, what you're seeing on here represents on a 7-day rolling average over 17,000 doses administered in our state a day, which is in the top quartile of how other states are doing right now. Next slide, please. This is another picture from our dashboard, and it represents, and here just to give you a pretty high level look, this looks at how we're doing on vaccinations at a county level, and this is specifically looking at people vaccinated per 10,000 county residents. The darker blue represents those who have a higher rate of vaccination per the county resident population. The differences are multifold and something that we're paying attention to as we're putting forward our allocations. Some of these relate to the density of the population in any given area. For example, perhaps an example down in Southeast Oregon with Harney County, we have a minimum dose delivery that we have to abide by in terms of how these are shipped. And so if you go by those increments of, say, 100 doses per delivery, that can pretty quickly get up there for a population. It also has to do with where we have some of our highest throughput vaccination clinics. So, for example, in the metro area, Marion County, Deschutes County, those are some of the areas that have had some really high throughput early on, and we're able to move doses pretty quickly. We continue to look at this to use this information in part to inform our allocation in our ongoing operations and support to vaccine efforts statewide.
Could I add one thing here?
Please.
So just based on our number of cases as well as our vaccinations, right now it looks like we've got probably 15% of Oregonians who have some level of immunity. They've either received 1 or 2 doses of a vaccine or they had COVID. Now that doesn't include people who may have had COVID and never got reported to us. So the real number is likely higher. But in any case, we are still a long way off from any kind of herd immunity in Oregon. So I just wanted to emphasize that even though we're getting lots of vaccines rolling out and things are moving swiftly, it's still going to be months before we're going to see a big dent from the vaccination and the herd immunity.
Thanks for calling that out, Dr. Jean. Next slide, please. This gives you another look at vaccinations data we're able to capture. This is not our real D data. It is what we've been currently situated to be able to collect through our alert system. You can see both vaccinations by race, ethnicity, sex, and by age groups. I guess a couple of comments. Largely, we see that we're have a much higher vaccination rate in our state for individuals who identify as white compared to those of other races. And you can see a fairly strong spread across the age groups, of course, with the exception of the youngest. And that is representative of those who've been eligible for vaccines so far. One thing that we are looking at this data closely and certainly considering moving forward, which I will speak to in a few moments, how do we ensure that we have vaccine access that is really culturally responsive, meets the needs of individuals. We're getting, doing outreach and communication that is both linguistically and culturally responsive, addresses some of the ongoing fears and mistrust related to vaccines and so forth. So this data in part helps to ongoing and inform us, and we have a lot more work to do. I would also say to Dr. Jean's point earlier, while we are just moving into the phase of eligibility based on age solely, we have already vaccinated quite a few older Oregonians, as you can see here on this slide, and in part that is due to some of our congregate care settings that we've been vaccinating both residents and staff, so including our skilled nursing facilities, long-term care facilities, and beyond. And not only does this represent the age bands, but also those who've been perhaps most vulnerable in our state and beyond to COVID vaccine, in particular death. And so we're hopeful to see a pretty strong impact of that even from the earliest phases of our vaccination while we continue to roll out vaccine to the older age groups over the coming weeks. Next slide, please. I just wanted to share CDC is also tracking doses administered. There's actually several different dashboards that they show on the CDC website. I guess largely this shows that generally speaking, allocations coming from the federal government and moving vaccine through this is a learning experience for all states, and we're generally all working through these together. You can see there aren't, there's a handful of standout states who are a bit ahead in doses administered, but Oregon is sitting pretty strongly in alignment with many other states across the country, and just welcome you to take a look at all the data available on the CDC website if that interests you. Next slide. Just a couple comments about vaccine distribution, both to date and where we're headed. So with our first phase 1A eligible groups, a lot of vaccination efforts really started within health systems and hospitals through our tribal health partners and via our local public health authorities. We've also directly gotten vaccine to others who were eligible in phase 1A, like emergency medical service and other first responders, and those staffing urgent care centers who've seen a high amount of COVID or symptomatic patients. I mentioned the skilled nursing and other long-term care facilities. Those doses have largely been delivered through federal pharmacy partners. And then we've really, knowing that the operational challenges of these vaccines were quite different than your typical routine vaccinations, really focused early on some of the high throughput vaccination sites that could manage both the Pfizer cold chain storage requirements as well as just moving large doses with the operational challenges that come with them. As I mentioned, where we're focused right now is really thinking through how to ensure that we're, in addition to these high throughput opportunities and partnerships we've developed, how do we ensure that we're really targeted in ensuring vaccine access to a more diverse population, whether that be individuals who are facing a disability and hard to access or manage in a large mass vaccination site, or really need a more culturally specific approach, trusted partners to help deliver. So we are working on doing more of that targeted work right as we speak, with that ramping up, including starting to build out vaccination allocations and distribution through targeted federal qualified health centers. There is retail pharmacy work that I'll speak to in just a second, starting with the federal government, but we're looking to see where we might want to amplify that with our own state retail pharmacy partnerships, and in what communities that would make the most sense. Next slide. This is a little bit about the federal retail pharmacy partnership that is just kicking off. This was announced a handful of weeks ago by the federal government. They are partnering with a variety of different retail pharmacies across the country. In Oregon, there's 3 main groups, so Costco, Safeway, as well as a kind of conglomerate of independent pharmacies. This is really just kicking off. This week, stores began receiving relatively small numbers, but the first allocations to pharmacies from the federal government this week. I believe by the end of today, those doses will be received. And in the coming days, expecting those pharmacies to start vaccinating individuals. The locations of these pharmacies were really decided and distributed via the federal government, and we are just being able to really ramp up our partnership with these retail pharmacies locally to talk about what the long term looks like, where would vaccine doses in these pharmacies make more sense geographically, and so forth. But right now, it's really just the beginning of this experience. Each of these stores are going to get a relatively small number of doses, at least to start, 100 doses. And these are allocations that are on top of already the state allocations that we receive and distribute within the state. So you can get a sense of where the majority of these stores are coming through this federal retail pharmacy. We expect the estimation of around 12 to 13,000 doses coming into these pharmacies per week to be maintained and potentially to grow, but we have a lot more to learn about this, and again, just being kicked off right now. Each of these stores are anticipated that they'll do their own scheduling on their websites, and so I anticipate there will be a lot more publicity about this and information on those Costco, Safeway, and other pharmacy websites coming soon. Next slide. One more slide here before I pass it off. This is just to share with you, kind of engage you to visit our vaccine website listed up top. Just this Monday, we've added some new features of tools that can help people receive information about when they're eligible for vaccine, where they can find out and get up-to-date information about vaccine, as well as ultimately, as these tools are built out, where they can find vaccines in their local region. So the top section is the Get Vaccinated Oregon site. This is a Google-based tool. Right now, you can register to be someone who receives information. You can register for other people should someone need help being registered, and sign up to get information that's pushed to you. As this tool is further developed over the coming weeks, ultimately we'll be able to notify you of vaccination opportunities in your county or region. We also still have what we call a chatbot feature that currently also provides information about eligibility for vaccine. If you see the very bottom where it says hello there on the side, that is the chat bot. If you live in the Multnomah, Washington, Clackamas, or Columbia, as well as some parts of Marion County, you can use this tool to actually get you to a scheduling at some of the vaccine sites in those areas. I think if you click one more time, you'll see, there you go. That is where the chat bot is. So if you click on that orange dot, you can start walking through eligibility questions. And if in the counties that I mentioned, it will ultimately, if you are eligible, get you to a scheduler. I will warn everybody, because we still do not have enough vaccination, those appointments get filled pretty quickly, but they are rolling out at least once, if not twice a week, for new vaccine appointments. And it will indicate when to check back. Next slide, please. I am going to pass this to Dr. Cieslak to talk with us about news of the emergency use authorization application from the Janssen vaccine. Dr. Cieslak.
Hi, thank you. I do have some information that I gleaned from a presentation that one of the, a representative of the manufacturer gave to the Association of Immunization Managers last week. Near as I know, these data have not really been published anywhere, but as I said, they were presented in this public forum. So the vaccine that they have named Ad26-CoV-2.S, developed by Janssen Pharmaceuticals and going to be marketed by Johnson & Johnson in the United States, is a non-replicating adenovirus 26 vectored vaccine. So they took this adenovirus 26 and they inserted into it the genetic code for the full length of the SARS-CoV-2 spike protein, which, as you probably know, is the protein that enables the SARS-CoV-2 virus to attach to your cells and get in. They conducted a phase 3 efficacy trial in the United States, Central and South America, and South Africa, enrolling subjects 18 years of age and greater. For the 3 sites combined, they had 43,783 participants. Of those, 59% were white, 45% were Hispanic or Latino. Remember, one of the major sites was Central and South America. 19% Black, 9% American Indian, and 3% Asian. They excluded people with underlying immune system compromise, but not people with other medical comorbidities. Next slide. Through the course of the trial, they accrued 468 symptomatic cases of COVID-19. This includes both in the vaccine group and in the control group. And when the numbers were all put together, they found 66% efficacy in preventing moderate to severe disease starting 28 days after vaccination. So this was one of their primary endpoints and what was presented to us last week. There were some slight differences in measured efficacy in the 3 different sites in which they carried out the study. So in South Africa, the efficacy was 57%, and they noted that 95% of cases of SARS-CoV-2 infection that were circulating in South Africa at the time were this B1351 strain, where there's some thought that it may evade immunity that might be engendered by the other vaccines or by natural infection. In the United States, the overall efficacy was 72%, and in Central and South America, it hit the midpoint of 66%. They said that against severe disease, and I don't know exactly how they define severe disease, but 85% against severe disease. They did note that there were no hospitalizations or deaths in the vaccinated group after. So we were scratching our heads here wondering, well, what's severe disease if it's not hospitalized? And I don't have the answer to that question. Next slide. You may wonder about side effects. Now, there is a publication from the phase 1 to 2A study that Janssen conducted en route to doing the phase 3 efficacy study, where they were looking at different doses of the vaccine and side effects associated with them. So you can look at a side effect profile in last week's New England Journal of Medicine, but that study does not have the efficacy data. But in the phase 3 trial, they found fever in 9% of recipients. They noted it was grade 3 in only 0.2%, so about 1 out of 500 developed a grade 3 fever. Grade 3 being defined as it interfered with some normal daily activities, like you stayed home from work that day or you canceled an outing that you were planning on going on. Grade 4 is what they call a need for medical attention. So if a patient went to an emergency department because of a vaccine side effect, that would have been a grade 4 reaction, and they didn't notice any of those. Serious adverse events were more in placebo recipients than vaccine recipients. They didn't report any serious signals that made them suspicious that it's causing some serious reaction disproportionately in vaccine recipients. And they reported no cases of anaphylaxis among all of their vaccinated subjects. So armed with these data, they submitted an application to FDA for emergency use authorization last week on February 4th. And the FDA's Vaccine and Related Biologics Advisory Committee is scheduled to review these data in more detail and make a recommendation to FDA on February 26th. So if the pattern follows that of the 2 vaccines that have been authorized for use to date, we could expect a ruling by FDA within a couple of days after that. And then as soon as FDA authorizes the vaccine, then the National Advisory Committee on Immunization Practices will meet and discuss recommendations for its use. So, by the first week of March, I think it likely that we're going to see some recommendations. One thing that I didn't note on the slide was that Johnson & Johnson had contracted with the U.S. government to develop 100 million doses of vaccine by the end of spring. So, we could be seeing a flood of this vaccine hitting the shelves in the not too distant future. Thank you.
Thank you, Dr. Cieslak. Just one last slide and a response to a question that came through on a vaccine. So here on this slide, we've just provided a variety of different information, encouraging you to share or take a look at both our COVID vaccine provider page, which has a lot of information for those of you who are planning to, hoping to be providing or being a vaccine provider, especially as we are getting more doses and able to be more distributive in those doses. Information about how to enroll as a COVID vaccine provider. I will tell you right now, we have I wish I could remember the number, quite a large number of people who have enrolled as a COVID-19 vaccine provider. Many of those are not receiving vaccine at this time because of the limits that we have and some of the operational challenges about shipments and minimal shipment numbers, for example. But we anticipate, as Dr. Cieslak just described, as more doses of vaccine become available, we hope one day not to have that resource limitation, and the breadth of providers will be really critical to us. I also do want to just respond again to the comment that came in the chat box here, sharing the concern about the growing inequality in access to COVID-19 vaccinations, especially for people with poor access or skills using the internet. And how are the plans, what are our plans to address those inequities? I do want to call out here that we have been concerned about that and working to address some of those gaps. One, we have really, on the last point on this slide, we've really expanded on the resource of a statewide call center through 211. People can call 211 and get their questions answered and support navigating the tools to get access to vaccine. There are people readily available to be able to respond to both English and Spanish, and then free interpretive services for other languages should that be needed as well. We were having some problems in the last couple weeks with regards to wait times, and has just really significantly expanded on our capacity and language access through this tool. And as a report I heard yesterday, just really, really strong feedback of positivity about this tool supporting people, as really identified that the online tools are not really helping them, but this 211 tool is helping, as well as reports in the last day or two of really diminished to 0 wait times now. So we will continue to keep an eye on this and resource this as a critical tool. While not addressing the internet technology issues, I would just add in language access, our chatbot tool that I mentioned earlier is now fully translated into Spanish. We are working to expand that. There's some technology platform challenges, but working to expand that to up to at least 11 other languages. And the work in development of the Google tool that I also mentioned, Get Vaccinated Oregon, also working to actively provide broader translations. So thank you for the important question, and this is an area of particular focus right now. Next slide. Just one quick comment, and I'll welcome my colleagues to add any detail to this as you see appropriate. One update to OHA guidance on the next slide that I just wanted to call out. We updated just, I believe, last week our investigative guidelines that perhaps many of you do not, keep fully updated to this particular guidance. But it relates to vaccination and the need for quarantine. So back on January 20th, we adopted this new guidance that states close contacts who have been fully immunized with COVID-19 vaccine, according to the ACIP schedule, and are at least 2 weeks beyond completion of the vaccine series at the time of their exposure, are not required to quarantine. They still need to monitor themselves for symptoms of COVID-19 during the 14 days after exposure, and certainly if symptoms develop, should isolate and seek testing. And I will just note that CDC just, I believe, yesterday or in the last couple of days announced a similar approach. But Oregon has certainly had our eye on this, and really, I think one of the things that we're, one of the opportunities we see ahead with vaccination in terms of its impact on the need for quarantine. This will need to be reassessed as we move forward with these vaccinations, but really important. I will pass out, if we go to the next slide, and I am going to just pause before we jump into this next one, and I'm going to share a question that was asked by someone on our chat line, and see if any of my colleagues has an answer to this. The question is, how long will it take to know if the virus can be spread by someone who has been vaccinated or previously infected? And I'll make a comment and welcome my colleagues to chime in as well. As I think Dr. Cisak mentioned, particularly in his overview of the Janssen vaccine, the research has really been focused on the ability of these vaccinations to reduce serious disease. We have yet to have, to my knowledge, any detailed data related to the ability for someone to still transmit the infection. And I am not aware, I'm not up to date on any ongoing studies. So I'm going to open it up to my colleagues who have an answer to this question.
So you're asking whether vaccinated people can transmit, is that?
I think it's related to that, Paul. So how, whether they can transmit the virus, and then really the question is, how long will it take to know if this virus can be spread by someone who's been vaccinated or previously infected?
Right. It may take us a while, and it may take some special studies like, really measuring the amount of virus that someone who's vaccinated puts out. Let me say that, what we're saying is that it hasn't been proved that these vaccines will stop transmission. That said, I think we have a lot of reason to suspect that it will either make transmission a lot less likely or it may prevent it altogether. We just haven't proved it yet. And the reason I say this is, first of all, the way these vaccines work is that they generate an immune response after that part of the virus that gets into your cells. And if the virus can't get into your cells, then it can't replicate itself and can't spread. The question, of course, arises as to whether that immune response is as active in the nasopharynx as it is in the rest of the body. But at least one of the trials, the Moderna trial, did swab everybody before giving the second dose. So this is 28 days after the first dose and just before they're about to give the second dose, and they swabbed everybody to see whether they had virus in their nose. And they found virus in 38 of the placebo recipients, but only 14 of the vaccine recipients. So that would represent a 63% reduction in people having the virus in their nose, and that's just after a single dose. So you'd expect that it would be higher after 2 doses. We don't have those kind of data from the other vaccines, but as I said, I think we have a lot of reason to think that they may help. And the other thing is that we can't think of many other examples of vaccine preventable respiratory viral illnesses where vaccinating doesn't seem to stop transmission. You can run down the list of measles, mumps, rubella, chickenpox. In all of those cases, vaccination does seem to inhibit transmission.
Thanks, Dr. Cisak. One other question that came up was when can we expect new guidance for those who've been vaccinated regarding travel or other workplace restrictions? To my knowledge, we certainly are aware and considering this, but I don't have an estimated time for when we might be putting forward new guidance. Anybody else have any updates on that?
I don't, and I suspect we'll be taking our lead from CDC on this.
I agree.
Thank you. Okay, with that, I'm going to pass off to Dr. Smits to walk us through some literature and other related updates.
Great, thank you, Dana. Next slide, please. So I have just pulled some papers that I thought were kind of interesting. It's a little bit of a smorgasbord today. The first one was in this week's issue of JAMA. It was looking at saliva testing versus the usual kind of going deep into the nose. And they found 16 studies, of which just of note 8 of them are preprints that haven't been peer reviewed yet, and about 6,000 patients. These were outpatients that had generally mild illness. And the sensitivity for the saliva test was about 83% with specificity about 99, which was very similar to the nasopharyngeal swab. So I know that these tests are starting to be marketed. I believe they're actually, they might even be in drugstores that are over the counter or things like that. But just to be aware that that these saliva tests exist and they do seem to be pretty credible. Next slide, please. And then this is an update on Remdesivir. You'll all recall that Remdesivir is an antiviral medication that was kind of pushed out by the federal government to all of us as a treatment for COVID-19. The VA Evidence Center, I'm sorry, I probably got that name a little bit wrong, but they've been doing a living systematic review of Remdesivir, and they updated in the past week or two. They came out with an update in the Annals of Internal Medicine of their review. They included 5 new RCTs, and they found some, their findings are kind of tending to go more and more in one direction. So it doesn't appear that Remdesivir affects mortality, or it may or may not. It kind of it doesn't go over. It goes over 1 in that significance range. It definitely didn't decrease mortality in patients not requiring supplemental oxygen. But it does seem to have a sweet spot in those patients who are on oxygen, but they don't need any mechanical ventilation. That does seem to be where it's useful. But unfortunately, it seemed to show an increase in mortality for those patients who are on mechanical ventilation. So definitely got a little concern there. Next slide, please. And then these are just other findings of note. It didn't seem to increase. If you started it on people in the hospital, it didn't. There was kind of mixed results on whether that would prevent them from declining and needing mechanical ventilation. It did have a moderate reduction in median time to clinical improvement, and it had sort of a mixed effect on hospital stay. And then they looked specifically at 5-day versus 10-day, and they found that the mortality, that one little sweet spot of people on oxygen that aren't ventilated, the 5-day course seemed to be just as good as the 10-day course. Next slide, please. So in response to that, the American College of Physicians, they have sort of, going with the living review, they have these living practice points about Remdesivir, and they have adjusted those practice points. So they their first practice point is to consider Remdesivir for 5 days in hospitalized patients who are not requiring mechanical ventilation or ECMO. They no longer have the requirement for oxygen supplementation or severity of disease. They said that you could extend the Remdesivir course to 10 days if the patient does deteriorate and requires mechanical ventilation. And then they have a new practice point that they point out based on that worsening outcomes. If you start Remdesivir when somebody is on mechanical ventilation, they actually now recommend against doing that. Next slide, please. So that's the update on Remdesivir. For those of you who have breastfeeding women in your practice, I thought this was a pretty interesting point. This question has definitely come up in my practice. There was a new review that was published on SARS-CoV-2 in human milk because there are very few lactating women who have developed COVID. It's a small group, it's 116 women, and they only found SARS-CoV-2 in breast milk in about 2% of women. But interestingly, they did find some SARS-CoV-2 specific antibodies in the human milk. So basically, the conclusion was the breast milk doesn't appear to be a real vector for infection with the SARS-CoV-2. Of course, then you also have the infant's going to be at risk anyway if mom has it because of the close contact mom's going to need to do to care for the infant. But there might actually be some positives with the breast milk because you might get some antibodies. So based on this information, the World Health Organization recommendation is to continue exclusive breastfeeding unless there's other medical contraindications. So you can reassure your patients in your practice if they're breastfeeding. Next slide. And then this really kind of startled me. I hadn't actually come across anything that looked at smoking and SARS-CoV-2. You would assume, this being a respiratory virus, that smoking would be a risk factor, but I hadn't actually seen any published data on that. So there was a new paper, and I won't even attempt the first author's last name, but it was just published in Tobacco-Induced Diseases. It looked at 40 studies, and both current smoking and former smoking were significantly associated with increased disease severity. And they also was significantly associated with increased risk of death. So I mean, this kind of makes sense. We would expect that people who have an underlying risk factor, such as smoking, that would inhibit lung cilia and other, lung clearance, would increase their risk of poor outcomes. But this is the first time I've actually seen it conclusively shown, which makes me think that if you are starting to look at who in your practice down the line, when we can open up to all ages, which groups should be considered for vaccination, I think smokers definitely should be. Next slide. And I believe this goes back to Dana.
Thank you, Dr. Smits. Yes, on a slightly different note from the literature review, we just wanted to add a quick view that we thought might be relevant for all of you joining as healthcare providers. And this is just to really note the change in Oregon Health Plan or Medicaid enrollment in our state since the state of emergency was declared back on March 8th, almost a year ago. It has been a steady rise of enrollment into the Oregon Health Plan and represents that most recent date on Monday of this week, we're at 17% above our enrollment from just below a year ago. Obviously, this is critically important to ensure that people have access to the care and coverage that they need during this important pandemic, but also reflects likely the substantial economic impacts that have occurred for many in our state during the pandemic. So just wanted to share this with you. We're now at just over 1.2 million individuals enrolled in Medicaid at this time. So next slide, I think we are closing at an end here, and we can just answer a couple of the questions that are coming through. My colleagues have been responding, trying to respond real time, but I'll take a couple others that have come in. So there was a question about how are retail sites monitored for compliance to ensure they are not allowing non-eligible individuals to jump the line ahead of those who are eligible. And they're referencing a news report that I have not seen, but must relate to this topic. So first of all, I would say just broadly, in terms of eligibility and access to vaccine, Oregon is really taken, much like other states in the country, from an operational standpoint, an expectation of self-attestation that you meet the current eligibility. And so we are really asking for the integrity of our colleagues and fellow Oregonians to really please do not jump in line. There are reasons behind the phasing and sequencing, and really want to make sure that those most vulnerable have access to the vaccine, and to follow our sequencing plan. That being said, the federal retail pharmacies do follow state-specific eligibility criteria. We were asked over the last week to provide that eligibility through a survey tool with the federal government, and we update that once a week so that we can update it with emerging, for example, age groups that are coming up here in Oregon. So we have so far been told that that is going to be the eligibility that they are using, and asking our fellow Oregonians to please, as you're self-attesting to eligibility, to be please not stepping in line. We unfortunately know that that is happening, but we encourage you all to take part in passing on that message. I am going to just check. There was another question about plans to open vaccines to those in multi-generational households. So the question related to elders, so I will say currently, as I mentioned, anybody over the age of 65 will have access to vaccine based on our age bands as of March 1st. So we're week by week adding 5 years to the eligibility age group, starting with 80 this past Monday, moving to 75 on the 15th, and so forth. We do know that that does not capture all members of a multi-generational household. This was one of the recommendations from the Vaccine Advisory Committee to consider before going to the general population. And so we have looked at Washington State's guidance on this, and there's still work underway to look at how we would operationalize this. These sequencing would come after the age bands that I just spoke about. So more detail to come as we work through the recommendations and how we can put those into action. And if any of my colleagues see a question they want to jump in and answer, please jump in as I'm catching up and reviewing.
This is Dawn Mautner. I could respond to the question about the elders who are less able to access vaccine or vaccine appointments based on lack of access or facility with technology, computers and smartphones, etc. We are partnering with a variety of collaborators from FQHCs, primary care offices, to community-based organizations, and certainly DHS and the CCOs that have care managers and community health workers that already have relationships with individuals in the community and have been providing care for these folks to potentially do outreach, and that applies across the board, not just to the elders, but to others who might not be accessing vaccine for a broad variety of reasons, from transportation to language barriers to hesitancy. And that is where we depend on our provider and clinical colleagues out in the community, the audience for this call, to be talking with your patients and families about all the reasons that these vaccines are actually quite the miraculous invention. But that's one of our methods to do outreach to those with those by way of those partners who have essentially potentially better access and credibility with folks in those communities.
I can just briefly respond to one other question I saw here about Medicaid eligibility during the pandemic. And Dr. Mautner, I welcome you to jump in if you have more specificity, but I know there were actually quite a few changes in policy during this pandemic that actually allow people to stay on and specifically reduce some of the barriers for staying on. So I know they're listed on our website with regards to where we keep this dashboard of Medicaid enrollment over time. And so I think felt reassured there's a lot of activities that happen both at the federal and state level to ensure really the safety net of coverage during the pandemic, especially given all the significant economic impacts during this time.
That is correct. There is a standing policy in place that people are not being disenrolled during the pandemic from OHP.
And we'll give another couple minutes to some additional questions. One question that just came in about the Johnson & Johnson vaccine currently having their emergency use authorization reviewed. The question says, some vulnerable populations feel like they will get stuck with the Johnson & Johnson vaccine, which is not as effective as Moderna and Pfizer. What are the plans to distribute the 3 vaccines equitably? And I can share a comment and then welcome my colleagues to jump in. We are actively working to look at and review all of the efficacy data. Dr. Cisak outlined what is available now. We expect more information to become available as further review is happening over the coming weeks, with a lot of attention to look at efficacy and application both at a federal level and then with some of our West Coast partners. So those will all be really important steps to think about this. One of the opportunities, of course, with this vaccine is with regards to the 1-dose opportunity, especially where follow-up or access to a second dose may be challenged, but that has to certainly be considered with any efficacy data and how we operationalize this additional tool should it become available here as early as March. Dr. Cisak or others, do you want to comment on this in any other way?
Well, the only other thing I would say is to point out that the efficacy against severe disease was considerably greater. And if it were me and I didn't have much of a choice between the 2 vaccines, I would take the 85% protection against severe disease. That's pretty good as vaccines go.
Thank you. And I see another question here, important one, if any of my colleagues want to comment. Based on recent information from the CDC, is OHA going to change guidance and recommend wearing 2 masks versus 1? And I can certainly acknowledge that we are looking at that, but I want to invite my other colleagues to see if there's any update on where we're at with regards to the new CDC information. So I think this is relatively new just in the last couple days, and so I suspect that we are still actively reviewing that. We can certainly provide information at our next webinar with you all to keep you all updated on any potential changes from our OHA guidance.
That said, I think there is reason to understand that some masks are better than others, and we haven't been talking a lot about this, but there is an opportunity to examine what kinds of masks we're wearing and what kind of fit they have, and seeing if we can optimize that to improve the spread, since this is not going to be over soon.
Thank you, Dr. Mautner. Let's just end with 2 quick questions here and good ones. Just a question very quickly about, is OHA planning to penalize providers that are trying to avoid waste with vaccine? And the answer is no. We, of course, are asking for people to focus on vaccination and of course, self-attestation that you're eligible for our current phases, but we also do not want doses to go wasted. So the answer to that question is no. And I just will ask if any of my colleagues can speak to the question about our ability to detect rising variants of SARS-CoV-2, and we can close with that question. Anybody want to be able to answer that question? I know there's a lot of work, but please jump in if you have the details.
Yeah, well, I can take a stab. We're certainly sequencing in Oregon. The academic centers are doing sequencing of SARS-CoV-2, and our state public health lab, I think, is starting in the next few weeks. Right now, my understanding is they're focusing on some of the clearly identified variants that have clear clinical implications, like the UK variant. And I don't know how much they're able to test for novel sequences, but or novel variants. But I believe that is probably part of their capacity. But we are really focused on trying to identify how much of the UK and the South African variants are prevalent, and that is happening. Basically, specimens that have what's called an S dropout on some of the PCR tests, where the spike protein signal is not there, but they're still come back positive from the other 2 targets, that's an indicator that that could be one of the variants. And so those specimens, we're asking them to be sent to one of the places that is doing sequencing so they can be determined if they are one of the variants.
Great, thank you, Dr. Jean, and to all the my colleagues who helped share this information today. Thank you for joining us. Please, as you see on the slide, continue to join us there. We will continue to have these sessions once a month. In addition to the Project Echo COVID-19 response for clinicians, that's continuing to occur twice a month. And please do visit all of our information online. Great questions today and really important areas for our ongoing focus. So thank you for all the work that you do, and we'll see you again soon. Thank you.